Sir, so please meet our head of the institution. Unmute. Arul Selvan, sir.
Good morning, sir. Good morning.
Sir, good morning. Please meet Dr. S.P. Dhanbal, head of the institution.
We already met.
How are you, sir?
I'm fine, sir. I'm fine. How are you, sir?
Yeah, all well, sir. All well, sir. Good to see you.
Nice.
After a long time.
Yeah.
Family is fine, sir? All are safe?
Yes, sir. They're all fine.
Okay, sir. Thank you, sir. Thanks for joining, sir.
You have promoted in Mysore. Are you in Mysore, sir, now?
Hello, sir.
Are you in Mysore now or are you still in Ooty?
We are in Ooty, sir. Ooty, sir. Yeah.
Sir, can we go ahead and start, sir?
Yes, sir.
No, I'll just introduce, sir. Then you can start, sir.
Okay.
I'll just give an opening remark and then you can start. Okay. Shall we, sir?
Yeah.
Very good morning to all of you. Myself, Dr. Praveen, head of the Department of Pharmacology, would like to welcome you all for this live webinar on COVID-19 and neurological complication. For this webinar, we have a renowned neurologist, Dr. B. Arul Selvan, consultant neurologist, Royal Care Super Speciality Hospital, Coimbatore. I would like to welcome him on behalf of the department, on behalf of the institution, on behalf of our head of the institution, Dr. S.P. Dhanbal. So thank you so much for accepting our invitation and being here with us today, sir, in spite of your busy schedule. So with this, I request our beloved principal, Dr. S.P. Dhanbal, sir, to give his opening remarks.
Good morning to the resource person and also the fellow participants. Today we are going to have an exclusive webinar on the topic COVID-19 and neurological complications. It's going to be delivered by Dr. V. Arul Selvan, the consultant neurologist from Royal Care Super Speciality Hospitals, Coimbatore. On behalf of our Chancellor, His Holiness Jagatguru Sri Sri Deshendra Maha Swamiji of Suturmat, and the Honorable Pro-Chancellor Dr. P. Suresh, Vice Chancellor Dr. Surendra Singh, Dr. Manjunatha Registrar, and also the staff and students of JSS College of Pharmacy, Ooty, and also on my personal behalf, we extend a warm welcome to our today's resource person, Dr. V. Arul Selvan. And my compliment goes to the Department of Pharmacology, led by Dr. T.K. Praveen, and with the support of all his fellow faculty members, especially with the coordination of Dr. Justin, the department has come forward to organize such a wonderful seminar on this COVID-19 pandemic situation. This is the current need of the topic, and definitely the participants, I understand that there are more than 750 participants, delegates, including the internal and the external delegates from the other universities who have showed interest and also registered, and it's a very big number. And that too during the weekend, having this such big number is it's a very interesting and also appreciating, and also it motivating us. And so this shows the confidence on the resource person of the today's session. So with this, once again, I extend a warm welcome to our resource person, Dr. B. Arul Selvan, and also all our fellow colleagues from the Department of Pharmacology, and also from other departments of JSS College of Pharmacy, Ooty, and also the distinguished participants who are registered for this program. So with this, I wish you all success for this today's session. Thank you, sir.
Thank you, sir. Now I request Dr. Justin, the coordinator of this program, to kindly introduce the speaker of the day.
So good morning. It's my immense pleasure to introduce Dr. Arul Selvan. Has completed his DM Neurology from Institute of Neurology at Madras Medical College. Then he went to England to sharpen his knowledge in neurology. He passed his MRCP examination. He completed his training in Oxford under internationally renowned professor at Rodolphe Infirmary. He was appointed as a consultant at Walton Center for Neurology in Liverpool, which is a premier neuroscience institute in north of England. He was a consultant there for nearly 7 years. He was also nominated for fellowship by Royal College of Physicians of London, Edinburgh for his outstanding achievements. Apart from general neurology, Dr. Arul Selvan is interested in neuromuscular disorder, epilepsy, movement disorders, stroke, interventional neurology, headache, and nerve conduction and EMG studies. He is establishing a high-quality neurology service in Coimbatore, notably epilepsy surgeries for intractable epilepsy, movement disorder surgeries with deep brain stimulation for Parkinson's disease and dystonia. He was a leading member of team for epilepsy and movement disorder surgeries at Walton Center for Neurology. He is the first neurologist in Coimbatore to do deep brain stimulation for Parkinson's disease, and temporal lobectomy in intractile epilepsy. He is a kind and caring doctor and soft-spoken and well-linked by patients. He has done innovative techniques like intrathecal baclofen pump for chronic spasticity and diaphragmatic facing for cervical spinal cord injuries. Again, first time in Coimbatore. He presented numerous papers and posters in various national and international meetings. He has written articles in peer-reviewed international journals like Neurology and Journal of Bone and Joint Surgery. He is a respected and highly regarded teacher and taught several undergraduate medical students and postgraduates from various specialties. He was also supervisor for PhD and DPhil students at University of Liverpool, where he served as honorary lecturer in neurology. He is a member of Association of British Neurology and Indian Academy of Neurology and American Academy of Neurology and the British Society of Clinical Neurophysiology, to name few. He also conducted several courses, workshops, and invited lectures nationally and internationally. With this brief introduction, we welcome you, sir, and we request you to commence the session.
Good morning. Namaskaram to everyone.
Good morning, sir.
And this is a great opportunity was given to me. I have to sincerely thank Professor Dhanabal, Professor Praveen, and Dr. Justin to invite me again. It's always a pleasure to speak, being associated with the JSS colleges at Ooty. This is my third or fourth time, I think. So it's been immense pleasure to come back again and give us a lecture. Instead of coming to Ooty, I'm doing the Zoom lecture now today. Thank you to meet Professor Dhanabal again. It's wonderful, sir, to meet you. To start off, I'm just going to start on the neurological manifestations of COVID-19. Briefly, I'll introduce the subject about what is COVID and what thing has to be done as a layman terms, and then I'll go into the neurological manifestation with detail about that. So my theme of the talk is to be like this. It'll be briefly introduced, very simple, basic, what's about the virus and how does it spread. And then the pathophysiology, how does it invade the neural system and causes the damage to the central nervous system and the peripheral nervous system. What are all the neurological manifestations it can affect us? And then briefly about the management and conclusion. Feel free to interrupt or ask any questions at the end of the sessions, please. The coronavirus is COVID-19. What do you need to know? It is a severe acute respiratory syndrome, coronavirus 2. It is called the SARS-CoV-2, causes of COVID-19. 19 is the year 2019. SARS-CoV-2 is a new virus. It was first identified as a respiratory symptoms with a pneumonia in Wuhan province in China in late December 2019. By March, it is spread to the various worlds and the WHO has conferred as a pandemic. It probably started in animals, probably bats, and it's now spreading between the people. As the virus is still new, we are learning the antigenicity and antibody production so that the vaccine can be invented fairly soon. How does it been spread to the other countries? It's mainly the travelers. Many countries have detected almost all of them in the virus in travelers. Some people who were in contact with the travelers were infected by them. It is possible that almost every part of the world has got some corona patients or COVID-19 patients. How it has been spread? It's mainly spread by the droplets. So as we spread the influenza virus in cold, and then when we talk, when we cough, and when we sneeze, these droplets have been spread in the air, and it's become an airborne infection. People can get infected when these droplets enter the nose, eyes, and mouth. And touching the contaminated objects will also, like these are all called fomites, the secondary objects like pencils, computer screens, laptop, telephones, mobile phones. And if you touch these, and then it can also spread. Some people have been infected without any having symptoms. They're called asymptomatic carriers. What all the symptoms has been recorded so far? So far, the fever is the commonest symptom, followed by cough, sore throat, the general virological damage it causes of fatigue, shortness of breath if the respiratory system is involved. Sudden loss of smell and taste. This is very unique to the COVID-19. Sudden loss of smell and taste is almost seems to be pathognomical. We will discuss in detail why it is. And then headache, muscle aches, and some abdominal symptoms like diarrhea and abdominal pain. Symptom starts after 1 day after the exposure, up to 14 days, they can contract the symptoms. Some people have no symptoms and they are called asymptomatic carriers. So how do you maintain it, prevent to contract coronavirus? So we have to wash our hands very frequently with the soap and water, alcohol-based sanitizer, and cover your cough and sneeze so that you won't spread to the other people by preventing the droplets infection. Do not share the food and drinks and personal items, including the mobile phones. If you have any symptoms, then you need to seek the medical advice and isolate yourself. Always keep 1 to 2 meters in distance, especially in malls, temples, marriages, and other ceremonies. Avoid touching your faces frequently, eyes, nose, and mouth, and that's where it spreads. Avoid shaking hands. The Namaskar, the Indian Namaste, has been very famous even with the British. So they stopped shaking the hands, bow or nod, and culturally appropriate gesture, whichever suits them to greet this. Avoid activities which expose to large groups of people. So in Tamil Nadu, it's been a lockdown, and they've been announcing that the malls and cinema theaters will not be open. Work from home as much as possible and avoid non-essential travel. Avoid exposure, clean and disinfect the areas as soon as possible, and then every day keep away from the people who are sick. Don't let them cough or sneeze on you. Avoid visiting the hospitals, the high prone areas, especially the intensive care unit near and here, the ICU areas. So during this period, COVID infection, if you contracted the infection, it can be extremely stressful. So keep yourself in the best possible health, sleep well, eat well, healthy vegetables, fruits, and physically be active, doing a lot of exercise. Take breaks frequently, focus not to too much get the information about the coronavirus. It will be disappointing and discouraging. There can be a lot of pessimistic messages which will be going through in the media. So don't listen. Majority of them recover very well. 90% of them recover very well, except the minority patients to get infected and succumb to the infection. So this with the basic introduction, I'll go on to the minimum subjects. So the novel coronavirus is originated from the Wuhan city province in China. It started the first cases in December 2019. WHO, the World Health Organization, has confirmed as a pandemic in March 2020. Till to date, roughly around 5 million cases has been infected with the coronavirus, and then it's more than 300,000 deaths has been reported. It is caused by a severe acute respiratory syndrome, coronavirus, otherwise called SARS-CoV-2. So most common and important presentation is with the respiratory disease, but not with the neurological problem. 6 coronaviruses have been identified to infect the humans. 4 of them causes a seasonal flu-like symptoms like simple headache, body ache, malaise, rhinorrhea, and then it stops, accounting for 15 to 30% of the upper respiratory tract infection. Only 2 viruses which causes a severe pandemic, that is SARS-CoV 2003. Again, it originated from the Asian countries, especially from the China. The Middle East respiratory syndrome, which is in 2002, that's another pandemic which happened in 2002. How does it invade the central nervous system? The coronavirus as the primary target is only the respiratory epithelium. It goes only into the lungs. It is not a neurotropic virus at all. The target receptor is an angiotensin converting enzyme inhibitor. After entry into the cell, it multiplies in RNA is released in the cytoplasm, and then it is translated and replicated in the cytoplasm. After the formation of the envelope protein, the incorporation of the RNA into the virus, it is released into the circulation. The angiotensin converting enzyme receptors are found in the neural glial cells and also in the spinal neurons. That's why there were a lot of neurological manifestation. The mice experiment confirms that the coronavirus enters the brain through the olfactory epithelium. That may be the main reason why the patient has got anosmia and ageusia. Anosmia is the loss of smell, ageusia is the loss of taste. This may be the reason the virus enters through the olfactory epithelium. On the way of entry, it causes damage to the olfactory nerves and causes the anosmia. Viremia, when the virus enters into the blood circulation, also causes damage to the blood-brain barrier, and then the virus can directly enter into the central nervous system from the blood. Occasionally, virus can also enter into the peripheral nervous system by breaking down the nerve terminals and entering into that. The central nervous system damage can be postulated by 2 problems. One is a hypoxic brain damage. When there is pneumonia and the respiratory problem, and they get a hypoxia, and then the hypoxia can cause a brain damage. And second thing, the virus can cause the immune mediated damage. How does it do? We do that. We'll see that. It's a severe pneumonia can result in systemic hypoxia, causing a very severe brain damage. And then increased accumulation of the carbon dioxide, which is called hypercarbia, can cause a local vasodilation. Again, it causes more damage. Anaerobic metabolism with accumulation of the toxic compounds. When the immune cascade has been released and the immune cascade has been started, and then it produces various chemicals like leukotrienes, and then these leukotrienes is potentially toxic to various endothelium, including the central nervous system and the respiratory system. This results in neuronal swelling and brain edema. So it is called cytokine storm. Interleukin 6 is the level we measure when the patient has got a cytokine storm and they're rapidly deteriorating, and then the hypoxia settles in and the interleukin 6 level increases. And then we have to use special drug like monoclonal antibody, tocilizumab, to sustain or suppress the cytokine storm. How does it produce the cytokine storm? There is a release of interleukin 6, which causes a vascular leakage and activation of the complement, and coagulation cascade has been activated. That's why they get a lot of thrombosis, pulmonary embolism, cerebral venous thrombosis, stroke, and peripheral deep vein thrombosis also. In some patients, the coagulation cascade has been initiated and caused disseminated intravascular coagulation, thrombosis everywhere, and the patients die, which ultimately causes the end organ damage. It's all started by this virus, which initiates the lymphocyte activation, macrophages, and endothelial cells. So what are all the CNS manifestations? The central nervous system manifestation can be very simple, like headache and dizziness and vertigo. And then the serious disorders can also happen, most often the cerebrovascular disease. This is the only virus which causes a stroke in young adults. So we need to be aware of these complications. So when the young patient comes with a stroke, suspect corona outbreak or COVID-19. Impaired consciousness, acute hemorrhagic necrotizing encephalopathy, simple encephalopathy, transverse myelitis, and then encephalitis, epilepsy, ataxia, anosmia. And then it can also cause a peripheral nervous system damage. We already discussed the peripheral nerves can be invaded by the toxic nerve terminals and then causes a peripheral nerve damage like Guillain-Barre syndrome, simple neuralgia, neuralgic type of pain, can also invade the muscles, and the muscle can get damaged, and it can cause a polymyositis, or simple myalgia, skeletal muscle injury, rhabdomyolysis. So we'll discuss each condition one by one. Encephalitis, we all know encephalitis is an inflammation of the absorption. Neurological manifestation were typical, and some of the patients do have been reported with neck stiffness, indicating there is a meningitis component also. Hiccups, ataxia is a poor balance, oscillopsia is a decreased vision or jumping vision, and the patient cells, particularly the lymphocyte seems to be stores SARS-CoV-2 was involvement of the temporal lobe status epilepticus. In one patient has been reported. High dose of corticosteroids at the initial period seems to be suppress the immune breakdown so that it prevents the damage and host inflammatory responses. The initial signs, like any other viral infection, they do present with non-specific headache, malaise, tiredness, weakness, nausea and vomiting, and abdominal pain. And then later on, if they deteriorate the level of consciousness, they go into the deep coma. And they can have altered mental state. Also, they become confused, delirious, disoriented, Hallucinations, especially visual hallucinations, they think that somebody is standing there when nobody is there. Agitations, restlessness, irritability, personality changes. Suddenly they become very angry against a very close relatives. Behavioral disorders, the circadian rhythm seems to be disturbed, so they will be sleeping more on the daytime and less on the nighttime. Occasionally, a frank psychosis has also been reported as a part of manifestation of encephalitis or encephalopathy in COVID-19 patients. Seizures are another important manifestation. More than 50% of the patients do have seizures when they have a CNS involvement. Severe neurological deficits like hemiplegia or monoplegia has also been reported. Every possible neurological focal deficit has also been reported. The patient can, it all depends upon the site of the involvement of the brain. If they have a left hemisphere is involved, they present with the speech disturbances. When the posterior fossa like cerebellum is involved, then they do have a ataxia and the hemiparesis with the breast dependent jerks. Involuntary movements when the basal ganglia has been involved. And cranial epilepsies when there is a base of skull base is involved with extraocular nerve. Palsy is third nerve, fourth nerve, sixth nerve, and seventh nerve is the commonest one. It has been affected in COVID-19. And this is a typical MRI of the one of the patient, which shows the you can see that there is a temporal lobe involvement. This is the temporal lobe. And you can see high intense signal changes. This is a lateral part of the temporal lobe, and this is a medial part of the temporal lobe called hippocampus. They're very specifically affecting that part. This is the asymmetrical involvement of the right temporal lobe and the left temporal lobe. And this is not from COVID-19, this is only from the herpes encephalitis. Clinical consideration, what will be the CSF lumbar puncture will show the normal glucose, unlike in bacterial meningitis where the CSF sugar is very less. The protein will be marginally elevated. There is a lymphocytic predominant confirming it is a viral infection. And sometimes the CSF polymerase chain reaction for COVID-19 seems to be positive. Encephalopathies, it's not a direct invasion, it's a reflex mechanisms causing the brain to swell up, brain edema causes, and the pathophysiological process in the brain that usually develops an infection following few days. And it does causes changes in personality, confusion, and irritability. The largest study has come from the Wuhan province. They followed up to 214 patients who had a CNS symptoms and dizziness and headache and impaired consciousness seems to be the highest presentation. Acute disseminated encephalomyelitis, otherwise known as ADEM, it's a syndrome of multifocal demyelination, either associated with the infection along with the infectious process, or once the infection settles 1 or 2 weeks later, they present with the focal neurological symptoms. 2 patients have been reported. They do have a normal CSF because it's some kind of signature mark which has been left with the COVID-19, and then the damage happens a little bit later. The only abnormalities which we picked up is the MRI. MRI showed some high signal changes, and then they improved with the treatment of high dose of steroids, methylprednisolone 1 gram for 3 days, and then intravenous immunoglobulin. Acute hemorrhagic encephalopathy is another manifestation of the encephalitis of COVID-19, initially reported from USA, a 56-year-old female, 3-day history of fever and cough and altered mental state. And the MRI showed a hemorrhagic rim enhancing lesion in the bilateral thalamus, medial temporal lobe, and subinsular regions. And the patient received the intravenous immunoglobulin, and they do show some improvement, but not a complete improvement. Acute hemorrhagic encephalopathy has also been reported in very rarely with influenza virus, but it seems to be a bit more with the COVID-19. Transverse myelitis is another reported cases. So what is transverse myelitis? It's an inflammatory lesion occurring in the spinal cord, either completely or incompletely, and then characterized by subacute or acute motor weakness of the legs and arms with autonomic dysfunction, which means involvement of the bladder and bowel. Myelitis means inflammation of the spinal cord. Transverse means simply it occurs at the horizontal level, so that's why it's called transverse, across the width of the spinal cord. It causes the demyelination of the focal area of the spinal cord at the horizontal level. It can be caused by the infections, non-infectious agents, and sometimes idiopathic causes also but we are focusing only on the COVID-19. There are other viruses which can cause the transverse myelitis, like enterovirus, herpes virus, Epstein-Barr virus, rabies also, and AIDS virus, the HTLV1, human lymphocytic T-cell lymphotropic virus, which causes a tropical spastic paraplegia. Some of the bacterial infection can also cause transverse myelitis, but we will restrict only to COVID-19. Post-vaccinal myelitis has also been reported, especially after the rabies vaccine or influenza vaccine, and then rare inflammatory disorders like multiple sclerosis, neuromyelitis optica, which are all associated with anti-NMO antibody or anti-MOG antibody syndromes, has also got the transverse myelitis. So what's the immunopathogenesis? The virus causes the initiation of the lymphocytic activation and then the involvement of the both gray and white matter. It is not a purely demyelinating disorder. There is an inflammatory disorder which causes the destruction of the neurons and axons and oligodendrocytes and also the myelin. The autopsy reports have described that lymphocytic infiltration is a main cause of the event, which has been caused by the viral. Symptoms of transverse myelitis usually develop between hours to days. Sometimes it can rapidly progress within the period of 24 hours. There are three more major symptoms. One, you can have a motor symptom. They have a weakness and paralysis of the arms and legs. They can also have the sensory symptoms like paresthesia, pins and needles, numbness, or a clear-cut level of sensory loss from that waist downwards. An autonomic manifestation like loss of sweating, bladder and bowel involvement. These are all the important clinical manifestations of any transverse myelitis. When the cervical cord involved, then you get a quadriplegia. When the thoracic cord involved, you get a paraplegia. When there is a combination of upper motor and lower motor lesion, then you suspect a conus medullaris. Sensory symptoms usually, as discussed, loss of sensation below the level of inflammation, paresthesia, numbness. Lhermitte sign is when they bend the neck and then they get shooting like electric shock like sensations, and that's a Lhermitte sign. As we discussed earlier, if the lesion is in the cervical level, then they get a quadriplegia. When they get a thoracic level, they get a paraplegia. When they get a lesion at the conus medullaris, they get the combination of upper motor neuron and lower motor neuron signs and the bladder and bowel involvement. Complete means more than 3 vertebrae, that is longitudinally more than 3 vertical segments, symmetric involvement on both sides. Incomplete means incomplete involvement, only half of the spinal cord is involved, like Brown-Sequard syndrome. This is a patient with the COVID-19. MRI showed a high signal changes. In this, you can see that appreciate about 1 to 2 bright white signals in the thoracic spinal cord. There's another lesion in the cervical spinal cord. This is a different patient. You can see linear hyperintense signals, long segment myelitis has been reported. 1, 2, 3, 4 to 5 segments has been reported. So how do we confirm the diagnosis? Again, the CSF study will show marginally elevated protein, sugar will be normal, and then the lymphocytic predominant pleocytosis will be there. And the MRI will further confirm, in some cases CSF shows a COVID-19 has been positive. Sometimes the MRI can be negative, and then you need to be a little bit more careful in dealing with those patients. Again, some more patients are showing a long segment myelitis. These are all not from COVID-19, but this is a patient who had a anti-NMO antibody syndrome positive. She's got a long segment myelitis. You can see that the involvement of one from here, 1, 2, 3, 4, 5, 6, 7, 8, very long segment myelitis. So what's the treatment? In addition to the remdesivir, steroids seems to be very helpful, and then corticosteroids, typically methylprednisolone 1 gram intravenously for 3 to 5 days. And the plasma exchange is a form of hemodialysis. Using a different membrane filter, you filter out the antibodies and then reinfuse the plasma. So acute myelitis again has been reported from Wuhan. A 66-year-old male presented with a fever and body and headache, developed a flaccid paralysis of bilateral lower limbs, a sensory level at the level of T10, and urinary and bowel incontinence. The polymerase chain reaction seems to be positive for the COVID-19 in this patient. And this patient was treated with intravenous immunoglobulin, which is expensive. and then steroids and combination of antivirals. And then he was better and discharged. So the main pathophysiology of this either transverse myelitis or the respiratory involvement, it seems to be a cytokine storm, increased level of interleukin 6, and then other inflammatory markers like in serum ferritin, C-reactive protein, and interleukin 6 seems to be helpful in managing these patients. So as I told you earlier, the cerebrovascular seems to be a unique presentation in viral infection with the COVID-19. The CV has been reported in 6 to 10% of the patients in COVID positive. 5% had an ischemic stroke, 1% had intracerebral hemorrhage, and 1% had a cerebral venous thrombosis. And cases have been reported in most all literatures in all over the world, that including India, Italy, Wuhan, USA, Netherlands, and it specifically affects more than age of 60 years. Many had comorbidities like diabetes, hypertension, and hyperlipidemia. It seems to be median days of about 10 days after the respiratory illness. Once the respiratory illness started, and then the endothelium has been damaged, and the cytokine storm has been set on, and then after that the patient developed into the procoagulative state and developed subsequently the stroke. And some of the patients have been associated with aortic thrombosis and limb ischemia, again indicating a thrombosis in the aorta and also in the peripheral vessels. Deep vein thrombosis has also been reported, and we talked about the pulmonary embolism. The D-dimer, the blood D-dimer concentration seems to be very high. Serum ferritin is high. ESR, CRP, the other inflammatory markers, all seems to be high, indicating that the patient is entering into the procoagulopathic state. Patient needs anticoagulation like low molecular weight heparin or Fluxion or heparin. They are all positive. Some patients showed a positive lupus anticoagulant, anticardiolipin antibody, and anti-beta-2 glycoprotein. And one antibodies have been reported in COVID-19 associated stroke. As I discussed earlier, the low molecular weight heparin is recommended and indicated. How does it act? It does act on the damage of the endothelial cells and active inflammatory, and then the coagulation cascade has been initiated and suggesting a thrombotic pathways has been damaged. Endothelial dysfunction can potentially indicate micro and macrovascular complications for all of these patients. We discussed earlier the anosmia and ageusia. Anosmia is a loss of smell. Ageusia is a loss of taste. And then first has been reported from the USA and initially from the Wuhan province also. It seems to be unique for COVID-19. Again, why it happens? Because of the damage to the olfactory epithelium. And then the olfactory epithelium is the one who is responsible for conducting the smell. It's an end organ damage, and then the smell cannot be transmitted to the olfactory bulb and the entorhinal cortex in the brain. So smell function and taste function is commonly reported as loss of sensations, and it's very unique for the COVID-19. As the peripheral nerve damage, and we come to the Guillain-Barre syndrome. Guillain-Barre syndrome is an acute polyradiculopathy characterized by rapidly progressive symmetrical limb weakness, and then reflexes have been lost with minimal sensory symptoms but no sensory signs. Some patients do have ascending paralysis. It is called Landry-Guillain-Barre syndromes, and they have bilateral facial weakness also. So how do we confirm the diagnosis? Doing the lumbar puncture, we showed elevated CSF protein, and there won't be any cells. It has been described as albuminocytological dissociation, and the nerve conduction study showed a typical demyelinating polyneuropathy. COVID-19 has been reported with the GBS, the Guillain-Barre syndrome, from China, Iran, Italy, and States also. Zavo reported the first case, a lady of 61-year-old female presented with acute onset of leg weakness, bilateral symmetrical weakness, severe fatigue, and progression of weakness happens in one day. This is a typical presentation of a Guillain-Barre syndrome. Started out with backache, leg pain, paresthesias, minimal sensory symptoms, and then the motor weakness, which is slowly ascending over a period of 1 to 2 days. And the nerve conduction study will show a typical demyelinating polyneuropathy, the dispersion of compound muscle action potential, slowing of the conduction velocity, both sensory and motor, but sensory will not be affected as much as we expect. And upper limb and the lower limb will also show features of demyelinating peripheral neuropathy. These patients treated with intravenous immunoglobulin with a good recovery. SADAC From Iran, he reported again some more patients, 61-year-old male. The patient was diabetic, cough and fever, dyspnea 2 weeks before, indicating a viral infection, and COVID-19 is positive. And this patient also had ascending paralysis and bilateral facial weakness. Nerve conductions again suggested combination of demyelinating and motor axonal neuropathy. He was managed with intravenous immunoglobulin and he improved well. So to date, it has been about 19 patients have been reported with the Guillain-Barré syndrome. All of them are COVID positive. 2 of them died because of a severe respiratory paralysis. They need to be intubated and kept in intensive care unit for several days, but they could not wean him up and died of respiratory failure. 12 improved and 5 had a minor residual weakness, and they are also showing a continuous improvement. So overall, 17 patients showed a very positive outcome, except a couple of them which they could not save. The pathophysiology remains the same for idiopathic Guillain-Barré syndrome, a post-viral polyneuropathy, which is nothing unusual about a COVID-related Guillain-Barré syndrome. They also respond very well to the treatment, and the responsiveness to the intravenous immunoglobulin seems to be well. We'll just do one case study. A 40-year-old woman presented with on 17th March. She presented with nausea and diarrhea, severe myalgias 1 week previously. Coming to the hospital, he had a paresthesia, which is a creepy crawlies in the legs more than arms, and weakness of the legs started on 25th of April, and then it started progressing, and then it involved the upper limb, so she could not do the handwriting, and the handwriting becomes a hen scratch. Initially, a lumbar puncture was done, which was normal. Nerve conduction study showed absent H reflexes and F responses. In Guillain-Barré syndrome, the earliest manifestation could be in the nerve conduction study, which can pick it up the abnormalities of the F responses and H reflexes. She is also diabetic for the 10 years, and she has hypothyroidism. There was no sphincter disturbances. She complained severe low back pain and mild postural lightheadedness. She did not have any great respiratory symptoms except a cough and no shortness of breath or palpitation. Blood pressure was normal, indicating there is no autonomic neuropathy, and mild weakness of the neck flexors. Upper limbs were 4/5 and the lower limbs were 3/5. Sensory examination was normal on her, but the deep tendon reflexes were absent in the triceps and ankle, whereas in the biceps and supinator and the knee jerk were obtainable with only on reinforcement. Plantars were flexors. The MRI did not show any compressive elements, and she was treated with intravenous immunoglobulin 0.4 gram per kilogram body weight, which is a standard dose for recommended for Guillain-Barré syndrome, and then she improved remarkably well. Repeated nerve conduction studies showed improvement, and then some minor abnormalities in the F waves with the coronal dispersion. At the time of discharge, she was ambulating fairly well with the Zimmer frame, with the Walker frame, and then she is showing continuous improvement in the follow-up. But there were some persistent paresthesias in the legs for which she was getting gabapentin. So the typical Guillain-Barré syndrome is usually the case, and then they present with like paresthesias usually starts with the disease, and then the Guillain-Barré syndrome is a symmetrical motor weakness in the arms and legs with involvement of the respiratory and facial weakness. And loss of deep tendon jerk is a unique phenomena, and then they do have sensory symptoms, but the sensory signs like loss of vibration, loss of touch perception will be absent. And the lumbar puncture will show a characteristic albuminocytological dissociation, which means that there will be elevated protein, but there won't be any cells. Whereas in transverse myelitis and bacterial meningitis, there will be elevation of the cells, elevation of the protein, sugar will be less. But in Guillain-Barré syndrome, there will be elevation of protein alone without any disturbances in the sugar, and there won't be any cells. That's what called albuminocytological dissociation. Recovery does happen, but it will take weeks to few months. And this is Landry, a French neurologist who invented the Guillain-Barré syndrome, or who described the Guillain-Barré syndrome, so that the neurological illness has been named after them. And this is in 1916. They documented their observation in the French Neurological Journal. And this is a typical pathophysiology of the, you can see that there is a myelin sheath, looks like an insulation in the wires, as we see commonly the insulation in the wire. And that insulation or myelin sheath has been lost by damage by the virus-mediated inflammatory responses. And this is nodes of Ranvier, this is myelin. When the myelin has been lost, you cannot conduct the nerve impulses and the patient develops a weakness, and that is called conduction failure or conduction block. And the myelin sheath has been remyelination, and that's why the recovery disk happens. Coming to the end of the lecture, so myalgia and myositis. Mao reported the muscle involvement in 17 patients and 6 patients in a severe, non-severely ill group and 17 in the severely ill group. It indicates that the direct muscle damage because of the virus, and the creatine kinase should be more than 200 in some of the patients. Probably the direct effect on the virus into the muscle and causing the muscle damage. It could be infection-mediated immune responses, which can also cause muscle damage. But unfortunately, we could not do any EMG or a muscle biopsy in these patients. To conclude my talk, COVID-19 primarily affects the respiratory system, but the neurological manifestations are uncommon, but it's becoming increasingly recognized. About 10% of the patients need to be aware, unless otherwise we will lose the patient, and it has to be detected early and managed early with very well knowledge. Neurological illness may proceed in some respiratory system involvement in some patients. Hypercoagulable states, prothrombotic state, and cerebrovascular disease like strokes seems to be an important neurological manifestations in COVID-19, which is not been reported in many other viral infections, which is very, very important. It's rarely seen in other viral conditions. What will be the future directions? Overall, the proportion of patients with neurological manifestation seems to be small in compared with the respiratory system manifestation, because many of the patients do present with a fever, cough, cold, and only in 10% of the patients they do present with the neurological manifestations like headache, dizziness, vomiting, encephalopathy, and then encephalitis, facial weakness, neurological illness, and neurological paralysis. Expectation is that 50 to 80% of the world population might be infected before the herd immunity develops. Healthcare planners and policymakers needed to be aware of this growing burden, because it causes economic disasters, sequences, sequelae, complications, financial strain, stress, loss of business, whatever you name it. All the industries have been affected: healthcare industries, transport industries, and it's caused enormous damage to the growth of the country, especially the third world countries like some of the countries have been struggling to meet with this pandemic. So careful clinical and diagnostic and epidemiological studies are needed to help define the neurological manifestations. Thank you very much. I'm happy to take questions, please, if there are any. Justin, sir?
Thank you, sir. Thank you for your wonderful session, sir. Very informative session. A couple of the questions are there. I request our senior professor, Dr. Anand Vijay Kumar, to take over this session.
Thank you, Mr. Justin. So thank you, sir, for your wonderful presentation. So there are few questions asked by the participants, sir.
Yes, sir.
Okay. So one question is it possible to use SARS-CoV as a vector in aiding any neuro concerns, like a better targeted drug delivery system to the brain, or as a tool to deliver mutated gene, etc., or more importantly, as a developmental tool in smart drugs or nootropics?
Yes, sir. That's a wonderful question. I think the question, the participant has asked a question because there was an inventory that Duchenne muscular dystrophy, you all heard about that. Duchenne muscular dystrophy is a catastrophic primary muscle disorder which causes damage to the young children. So DMD gene has been delivered through a vector, virus vector. I think that's what the participant is thinking, that whether the virus can be used as a vector or not. See, this virus is a new virus to us. We don't know the full detailed study of the virus. Although they have a spike proteins, we not invented the vaccines and anything. It's too early to conclude that this virus has been used or cannot be used as a target for the gene therapy. So we need to wait from the all over the world before it can be used as a vector. vector. But my personally think is that I don't think we can use as a vector, virus vector for the gene therapy in this scenario now, because we are not fully understood about the virus and we are not yet detected the vaccines. And without any vaccine, if you inject a virus into a patient, and the patient can be potentially COVID positive and they can spread the virus to the others. So it's not in this state at present now.
By Mrinalini, I noticed a point in your slide saying corticosteroids can be used in encephalitis caused by SARS-CoV-2. But since suppression is immunity or side effect of corticosteroids, I wonder if that would be a contraindication by putting the patient at higher risk towards infection.
Yeah, that's a good question. We always think that the steroids, when you give, the immune suppression happens, and then there will be a potential complications of another reinfections or super added bacterial infection, but that's not the case at all. The viral infection causes the immune storm, immune mediated immune responses. So we are suppressing only the immune responses by giving steroids. These steroids are given only for the short-term period. It's been recommended by the American Academy of Neurology, endorsed by other neurological societies all over the world. So by giving the steroids, either high dose of intravenous methylprednisolone or dexamethasone, we suppress short-term immune response which is caused by the virus. So it will be beneficial to the patient, and many patients have been recovered very well by giving the steroids. So we don't need to worry about the secondary infection and other things.
So one more question.
Yes, sir.
Is it safe to use AC inhibitors in patients with COVID and hypertension?
That COVID, the AC inhibitors have been tried, because I told that the AC inhibitors is the one which is the target virus has been bound and causes subsequent damage. Although it is not evidence-based, but some patients we do try with the angiotensin converting enzyme 2 inhibitors. So it can be tried that way to control.
Okay, thank you. The last question is, what are the chances of COVID-19 patient getting neurological manifestation post-discharge?
That's a very good question. Again, we discussed a condition called acute disseminated encephalomyelitis. After these develops after 1 or 2 weeks after the virus infection, or any virus, influenza virus, so they do get the neurological manifestations 1 or 2 weeks. So these patients like ADEM and transverse myelitis has been reported when they discharged and they did get the neurological symptoms. So it can perfectly happen. So that's why the patients are clearly followed up after the COVID-19 infection for 14 days to see whether there are any worsening respiratory symptoms, because the patient do develop interstitial lung disease also. So to make sure that they do not drop the oxygen saturation level. At the time, we also look for the neurological manifestations. So your delayed neurological manifestations like acute disseminated encephalomyelitis or transverse myelitis can happen with the COVID-19 patients 2 or 3 weeks after the discharge. So they should be closely followed up.
Has been completed, and I thank you very much, sir, for your presentation and also the answering the participant questions that has been asked based on your presentation. So I thank our principal, Dr. S.P. Dhanabal, for providing this opportunity and inviting Dr. Arul Selvan for this presentation. And also I thank our department head, Dr. Praveen, for making this and wonderful session. And I also thank Dr. Justin for making this arrangements, and also the IT department of our team, Dr. Jaykumar, for making this happen and without any difficulties. Thank you, sir.
Thank you very much, sir. Thanks for the opportunity given to me. Many thanks for the faculty members, especially Justin and Dhanabal, sir. Thank you, sir.
Thank you.